We are Rohan Gala from India,
That's Evangelisti from Italy.
members
Hello.
of the new Aospine Youth Club.
Welcome to the Expert Insight series, where we interview worldwide expert spine surgeons who kindly share their professional and personal experience with us.
And today we have the privilege of interviewing a distinguished figure in the field of orthopedic surgery. With a career spanning back to 1992, our esteemed guest played a pivotal role in establishing an orthopedic and spine department at Ganga Hospital, which has now evolved into one of South Asia's largest specialty hospitals with 650 beds and 40 operating theaters. This accomplished surgeon's focus on research has been nothing short of extraordinary. They founded the Advanced Center for Spine Research, equipped with cutting-edge facilities for proteomics, genomics, and cell culture. The accolades speak volumes, having received the ESELS Award for Best Spine Research 5 times and consecutively earning the NAS Outstanding Research Award for 4 years. Not only is our guest a prolific researcher with over 500 publications cited extensively, but their contributions have been acknowledged by Stanford University, placing him amongst the top 1% in scientific contributions to orthopedic surgery. Additionally, their leadership extends to serving as president of renowned organizations such as ASSI, ESELS, APSS, and the CSRS. We are honored to welcome our guest, Professor Rajasekaran, who has not only shaped the landscape of orthopedic and spine surgery, but continues to drive innovation and excellence in the field. Welcome, sir.
Thank you, Rohan. Thank you for the kind introduction. You're making me nervous. Yeah.
So a very good morning in New York and good evening to you, sir. And thank you for accepting our invitation. How have you been today?
Yeah, I'm privileged. Very happy to be connected with AO Spine. My journey with AO Spine is very long. And so it's really nice to get back and also through the youth side of the AO Spine. That's really an honor. Yeah, thank you very much for this invitation.
Okay, sir. So for our viewers, please tell us your full name, your specialty, and your current position.
Yeah. So Rohan, I'm Dr. Rajasekaran. So I'm currently the chairman and head of the Department of Orthopedic Surgery and Spine Surgery in Ganga Hospital, Coimbatore, India. So many people may not know on the international scene about Coimbatore. So it is a city in South India. By Indian standards, it's not a big city, but still it has a population of more than 4 million and a surrounding rural population of another 4 million.
Wow.
So we are privileged to be over here. It's a nice place to live in, a very nice, cozy city. So very happy to be here. Yeah.
Okay. And Dr. Rajasekaran, where have you been trained and when did you complete your residency?
So my basic medical was in the same city, Coimbatore, medical training, schooling. And then my 4 years of orthopedic training was in the Madras Medical College in Chennai. That's the capital of our state. And that's one of the premier institutes. So following that, I also had the privilege of being trained in UK for nearly 3.5 years. But during that period, I was more into training of arthroplasty and arthroscopy. Okay. And it was only in the last 6 months that I was finishing my training. By chance, I came across two people. One is John Dodgen, relatively not very well known, but one of the finest spine surgeons I have seen across the world in Alder H&N Hospital. And Mr. Gordon Findlay, a renowned neurosurgeon. It was really a privilege for me to come in contact with them and to train with them, which also changed my focus to spine surgery.
So which brings us to our next question, sir, as to how did you start spine surgery? Like how you started?
So my foray into spine surgery is not actually by design or desire. And I would actually say it is by chance and by necessity. So after my training in UK, I returned back to Coimbatore and then set up this unit. It was a very small unit to start with. just 17 beds and two operating theaters. And then a lot of good team, a lot of youngsters joined with us. And all of us were doing everything in orthopedics, and we were growing very fast. But the youngsters had an eye for arthroplasty and arthroscopy, and they chose that. And I was left to do spine surgery. So it was by necessity. But I quickly fell in love with spine surgery because I understood one thing. There are two things basically for a surgeon. One is technique, the other is the philosophy of the whole specialty. And maybe the arthroscopists will not accept it. But I think in arthroscopy and in arthroplasty, the technique is more important than the philosophy. There is nothing like understanding the knee joint. But I think in spine surgery, it's opposite. I mean, you really need to understand the spine, the balance, the disc biology, the muscle physiology, the whole biomechanics of spine. And also, the diagnosis itself is very difficult. It's very mature. It needs a lot of maturity. So I really fell in love with spine surgery because spine surgery was very different. Whereas in other fields, the surgery was more important. Whereas in spine surgery, the surgery was important, but a small part in the whole management of the patient curriculum. Yeah. So that actually really fascinated me into spine surgery.
Yes, I totally agree with you. That the diagnosis usually maybe it's the hardest part, and then knowing what to do and
what to do and also what not to do.
Not to do. Yeah.
Learning a surgery and then learning whom not to operate that surgery is very important.
That's, I think, a great message, especially for the younger of us. So, definitely. What do you think are the pros and cons of becoming a spine surgeon?
Well, I think this is exactly what we were talking about.
Yeah.
If you want to become a spine surgeon, I think you have to be ready to have a long runway into your career. The training of spine surgery has to necessarily be longer than in other fields. Yeah. And I can say this with certain amount of certainty because I was doing a lot of trauma, arthroplasty and arthroscopy in the early 1990s before specializing in spine surgery. And I can definitely say that your maturity into getting into an experienced spine surgeon or a mature spine surgeon takes much longer than what is necessary to become an arthroplasty surgeon or an arthroscopy surgeon. So if you're getting into spine surgery, I think you should be, number one, you should be a patient learner. You should not be impatient for success or to become a mature surgeon. And second, you should understand that it is not just techniques. I mean, you have to learn a whole lot of patient-centered approach rather than in many other fields. So your training has to be a little more complex and has to be under a good mentorship. I think that's going to be a very critical aspect for spine surgeons in training.
Thank you.
Yes.
No easy success is what I can actually say.
Yeah.
Yes. So if you think about your professional journey, like who inspired you back then and who still inspires you now to keep you going?
Yeah. So, Rohan, I think we are probably the last group of spine surgeons who could have become spine surgeons without actual formal fellowship in spine surgery. Many of us in our age group were self-trained. And I think probably that was also a good thing because we had a lot of original ideas and we were doing a lot of good things. If I had to think of my early inspirations, I would actually tell my Professor T.K. Shanmugasundaram, who was also doing a lot of spine surgery at that time. But, to say that I learned spine surgery is one thing. I learned a lot from him. But actually, he was one of those persons from whom I learned a lot about surgery itself. And when you mature into a surgeon, I think it's very important, because the first thing he always used to tell us is to become a very good spine surgeon, you have to be a good surgeon to start with. And to be a good surgeon, you have to be a good doctor to start with. You have to be a good medical man. And to be a good medical person, he said, you always have to be a good human person. You have to be a person who can connect with the patient. You have to be a humane person who has to have a good emotional contact with the patient. And that was something very important to learn. And he always used to put the patient first and the patient's interest in front of new technology. He was the first person who told me, okay, it's something very important. I think I can quote it here. He always said, there is no harm if you are not the cutting edge surgeon. He said, if you're the cutting edge surgeon, it's very good, but you will lead a lot of bleeding in your patients for something. Always stay 5 years behind the cutting edge technology. You will be the safest person for your surgeon. So I learned a lot of philosophy from him, and something of putting the patient first interest. And he was a great inspiration. He was also the person who first taught me publish or perish, because at that time, as you would know, 40 years before, publishing and research in India was at a very, very low ebb. And he used to actually say, if in the international arena you need to be known, you need to publish it. And he was a great inspiration. And AOSpine is another forum which allows you the possibility to move shoulder to shoulder with all the giants in the field of spine surgery. I mean, there are so many who inspire you all the time with their innovative ideas, with their capacity to do cutting edge research, new ideas. So I'm always grateful to AOSpine for putting me on to the. I believe that you're always the some average of the 5 persons with whom you are moving with on a close basis. If you move with the right persons, thinking in the right way and doing the right things at a high level, you are automatically elevated to that level. And there are the opportunity I have had in life to move with all the spine giants is really very, very good.
That's a great message. Thank you. Also for our club. One of the purposes of the mission of our club, let's say, is to get to every surgeon all around the world the chance to get into our spine, to make it easier, that you're not forced to have a great mentor to get involved into AO spine. So this is one of our mission. Thank you for saying those words about AO spine. We really appreciate it. And did you always wanted to become a spine surgeon, or do you have a different profession in mind?
Well, I had never aimed to be a spine surgeon to start with, but I always wanted to be a medical person. So because I am the third generation medical person in the family, my grandfather was a doctor, my father was a doctor, my brother is a doctor, many of my uncles were doctors. So there was always a medical talk in the family. I mean, you sit down to dine on the dining table and there is a lot of medical talk.
Okay.
And so slowly over a period of time, medicine was actually in our blood. So I always wanted to be a doctor, and I feel very happy of the good decision that I made of becoming a doctor. But after becoming a doctor, surgery was something I always thought was more interesting than being a medical person. And becoming an orthopedic surgeon and spine surgery evolved by chance, and I'm very happy for what happened.
So in moving on, so what would be your advice to young surgeons, or like the Gen Z in this era? A lot has changed over the years, but one advice, or some wise words to the generation today of young surgeons.
Yeah. So I think if you ask me what I would advise to the young surgeons, there are a few things, one or two things. I think the most important thing, something which I'm really concerned about, seeing how spine surgery training has evolved, is the shift of focus of training from the wards and the operating theaters to industry workshops, bone workshops, and labs. But this may be okay to learn the technique of surgery, but this is not the right way to learn spine surgery. So the spine surgery, the patient is everything. I mean, you need to listen to the patient, you need to talk, and you need to actually understand the patient. You need to clinically examine the patient. And if you don't get the maturity of getting the right diagnosis, then you may be doing the right surgery on the wrong patient. And this is something that we need to do. The first and foremost thing that I would like to tell the young surgeons are that please keep your learning in the wards. You need to spend a lot of time in the wards with the patient, because the patient can teach you more things than what any other conference or workshops can teach you. You need to learn surgery in the operating theater, not in the simulation. Because when you learn a surgery or the craft of surgery in the operating theater, then you are learning it from a mentor. And mentors can actually not only teach you the technique, but they can also teach you the indication, the nuances of surgery, when to operate, when not to operate, when to stop, when to have the surgical pause, when to go ahead. And this is very crucial for success in spine surgery. And so I would first and foremost tell them, please keep the learning in the wards and also for this thing. The second thing I would like to tell them is that this may look too simplistic and basic to say, but it's true that we need to never forget that the most important person and who should benefit from spine surgery is the patient. We have to keep the patient's interest as the foremost interest. And when we began our foray into spine surgery, there was only two people there, the surgeon and the patient. There was nothing other involvement. But nowadays there are too many stakeholders in spine surgery. I mean, there is the patient and the doctor, but more importantly, there is the industry, there is the corporate hospitals, the hospitals for whom you work with, the administration, also from the surgeon side, your peer pressure, competition, your dire necessity to be better than to others. So there is a lot of other stakeholders which are coming in, and sometimes the patient's interest may fall out of this thing. And if you fall a prey to all this and you lose focus on the patient, then there can be a big problem, because we may be forced, or there may be a temptation to do the most latest or your most favorite surgery or something which you learned in the last workshop on the next patient you see, and that is going to be a problem. So I would say that we need to keep the patient focus very high. And also, we have to be patient. As I said, in spine surgery, the young surgeon should always look at his mentor, the success that he has had, but he should not forget the long time that his mentor has had to reach to that level. You cannot climb Mount Himalayas on day one. So these are very important things that I think we should think of surgery.
Thank you. Thank you. That's a great insight. And you have already told us how you get into spine surgery, and we know that you have done a lot of work on spinal tuberculosis and correction of deformities. How did you get attached to this field?
I started my interest in deformities through the huge kyphotic deformities that was available in tuberculosis of the spine. And this actually started very early in my life. So I was a third-year resident in orthopedic surgery. And the institute that which I was training, the Madras Medical College, was the principal investigating site for the MRC trials. Now, this was an international trial looking at the outcomes of conservative treatment versus modified Hong Kong surgery for TB spine. And this trial had started 15 years before. And so patients were coming back for their 15-year follow-up. And by the time the interest in that trial had gone down, and so I was given the responsibility as a resident to look at follow-up and tick outcomes for all these patients who had come. And I was really surprised to see that many of the patients who have been marked as good outcome 5 years, 10 years before had actually a huge deformity which the patient was not happy about. And that made me wonder. And then I realized two things. One is that these people did not have a deformity during the treatment. And they didn't have a deformity when the healing of the disease took place. And these were the people who all had tuberculosis of the spine in their childhood. So because in the adults, the deformity was never more than 40, 50 degrees. And these children, even when they had healed the disease, when they went into the growth spurt, they had a sudden increase in deformity. But by the time these children had already been discharged from care, because 4-year follow-up, no recurrence of disease, and so they were discharged. But over a period of time, over 5 or 6 years, that deformity increased from 40 to 110 degrees, 120 degrees. And this was not reported before, that a late increase in deformity. And so I went to my professor and told him that there are lots of people who have not had a deformity during their initial follow-up and healing, but now are having. I got his permission to look at all the x-rays back. And that actually showed me another important thing. We always think that children with deformity increase in deformity. But we noticed another important thing, that 50% of children during their growth spurt in tuberculous kyphosis actually spontaneously improved their deformity. There were many children with 60 degrees kyphosis who became 25 degrees. They improved. And this was also not reported before. And that led to the most important question, why do some children improve and why do some children deteriorate? So we did a lot of analysis and found that in the children who all progressed in deformity, they all had a functional subluxation and dislocation of the facet joints. So these were the children in whom the TB has destroyed the anterior column, and as the kyphosis was increasing, the facet joint subluxed. And in biomechanical terms, this is called the global death of a column, because both columns are gone. And without the loss and support of the posterior column, the biomechanical force was so high on the anterior column that many vertebral growth plates, not only in the affected vertebra, but many segments above and many segments below, they stopped growing. And that's how they ended up with gross deformity. So, this was a very learning process. It showed us many things which were not reported before. Thousands of children worldwide were being discharged from care after 2 years, and they all ended up with massive deformities later. And we also described very simple radiological signs of facet dislocation and spine at risk signs, which really helped to show which are the few children who must be operated preemptively to prevent this deformity. And having got interested in this deformity, we also started looking at new techniques of how to correct the deformity. And that's how, I think in the late 90s, we described closing opening wedge osteotomy of the spine. So that was becoming a standard. So this was a good journey. And this knowledge actually helped us to look at other deformities. And now we know even in other areas like congenital kyphosis, achondroplasia, other forms of kyphosis, the same sequence of events happen in children. All of them have a dislocation of the posterior joints. And then we described the phenomenon of functional disruption of the posterior column. And this is an important phenomenon which has led to understanding the progress of pediatric deformities. So it was by chance. It was by chance.
Great.
So speaking of research, like a research is usually expensive and high tech, as they say, but for surgeons in developing countries with limited resources, do you think that they should do their own research?
Yeah. Rohan, this is also very close to my heart. So this is why I wanted this. You see, the purpose of research is to give you a solution to a problem which is worrying you. But if you look at all the publications, now you will find that 75% of the publications and research are coming out from 25% of the institutions. And 80% of these 25% of the institutions are from the Western world. I mean, this is quite natural because they have the research temper is there, and the research culture is there, research facility is there, and so this is a natural sequence. But if you look on the other side, 60% of the disease burden is in the developing countries. And this burden is completely different from the disease burden of the Western world. So you have a clear mismatch. There is a difference in the disease burden. The problems are different in the developing countries, and the problems are different in the developed countries. And we surgeons from the developing countries are trying to get solutions from what has been told for something different. For example, can the principles of stabilization be of pyogenic vertebral osteomyelitis be adopted for tuberculous spondylitis? Definitely. So there are many different things, but even for the same problem, the solutions is different. Because let's take a cervical disc prolapse. And if the solution is between iliac crest graft or a standalone cage or a cage plus plate or a cervical disc replacement. Now, the affordability of a cervical disc replacement may be actually the 6-month salary of a person in a developing world. But is it definitely required? Is it so necessary to have that 2 degrees more motion at one vertebral segment with 40% of people fusing spontaneously? So if you look at the problems are different, the affordability is different, the expectations of the patients are different, the requirements of the patient are different, and the cost provider is also different. So when everything is different, the solution alone cannot be the same. So it is very important that we have to find the appropriate solutions for our problems. And this can only come from research from every region. I'm not saying developing nations alone. I mean, every region is very unique. The requirements are very different. And so surgeons from different places, they must find their own solutions. And this is possible easily. Whenever it is research, we need not think about very high-class, cutting-edge molecular biology research. You can do clinical research. I mean, the whole trick, when I was the chair of the AO Spine, my theme was every surgeon must become a clinical scientist. It's not necessary for you to get into microbiology, microsomes, ribosomes, DNA, genetics. It's necessary. But if you take, again, tuberculosis of the spine, doing a genetic predisposition for multi-drug resistance is very important. But equally important is a clinical question. Can you stop your antituberculous therapy at 6 months or 9 months or 12 months. I mean, both are important for the patient and both are important for the society. Because if you unnecessarily give antituberculous drugs for 12 months when 6 months is sufficient, you are creating a lot of drug related morbidity, high costs. You are putting a lot of pressure on the society and the health economics. So every surgeon can always be a researcher. I mean, this can be in disc disease. I mean, how long should a patient be immobilized? What kind of exercise is good for them? Just ordinary simple things like does a lumbar corset is required after spondylolisthesis surgery? There are only 1 million clinical questions which can be answered by a very good research by any surgeon who is willing to document, follow up, and analyze his results. And every surgeon can contribute to the science of orthopedic surgery. So I think that one of the most important things for young surgeons in AO Spine, I mean in your AO Spine Youth Club, I think you should emphasize on the fact that we should all be surgeons, but also we should be clinical scientists.
That's
I think it's
great.
very
Yeah. I totally and personally agree with you. Thank you. And we have been talking about new technologies, different from countries and from one country to the other. I am really curious what you think about new technologies such as robotics or augmented reality, which now company in this industry are really pushing. What are your thoughts? I mean, are they fundamental for a spine surgeon in the future, or just something that we can maybe avoid sometimes or always?
So I have a disclosure to make because so we were the first in the country to adopt navigation, spine navigation. And we were the first in Asia to get the intraoperative CT guided navigation. And we are also one of the first people to get robotics and spine surgery. Okay, so I adopt and adapt latest technologies very easily, but only for a particular.
You have the expertise to answer to our questions.
Only for a particular reason. Mm-hmm. So I divide technology. I think technology is very important because if you look at the progress and advances in any field of surgery, the advances that can be achieved by improving human skills or your expertise in surgery, those days are gone. Because all that has been achieved 2 or 3 decades before. How to suture better, how to dissect better, how to do a surgery better, how to get hemostasis better, how to do surgery better. All that is, in fact, the surgeons 3 decades before have achieved it. In fact, I think they were much better surgeons than the surgeons of today because they depended on everything on their skills. All the advances, real advances that have taken place in the last 2 decades are the advances in technology. New instrumentation, new fluoroscopies, new imaging systems, new approaches which have been facilitated by new technologies. These are the real advances. So I think technology is extremely important and technology is going to lead us the way. So I, in my mind, as also the head of a department where I have to always decide on where to invest, on what technology and other things, I have classified technology in my mind into 2 things. The first group is technology which gives safety to the patient. Technology which will reduce complications. And in that, I have navigation, I have spinal cord monitoring, I have cell savers, I have advanced anesthetic equipments, and all that comes into it. And into this, I would, without hesitation, invest. Because when you are growing as a unit, the only one thing that will stop you or which can upset you or trip you down is to have unnecessary complications. Because complications actually absorb too much of your time, it changes your attitude, it takes away the confidence of the unit, and also your reputation. So one competition is equal to 20 big successes, I think. I mean, it's in that competition. So I would at any time give anything to reduce complications, and these technologies I would actually adopt. But there are other technologies which I think is more for the surgeon, and I would place robo right now in that. I mean, we adopted robo because we didn't want to be left out into the technology because I think it will be a future. It reduces irradiation for minimally invasive surgeries, and on that we eat. But other new technologies, like a good classical example is the lumbar disc replacement. Even though we were one of the largest units in the country, we were not happy to adopt it at all. We didn't do even one single because I always followed in these where there is a direct implantation into the patient or something. I'm always very happy to wait for 5 years to see the 5-year result and then get onto it. So we have to be very clear to think this new technology which is coming in, is it really for the benefit of the patient, or is it benefit for the industry, or is it benefit for the insurance, or is it a play toy which the surgeon really loves? Does it help him to feel better that I am actually a better person than the other person on the peer fight? Even if you take the disc, I think disc prolapse is a good example. We can discuss this. There is nothing that we have not done to the disc. So we have tried magnetotherapy, we have tried electrotherapy, I did and we have thermocoagulated, we have injected enzymes, we have injected different chemicals into the disc. There is nothing that we have not done to the disc. And if you look at the literature, there are more than 16 methods of intervention that has been described in the last 1 decade. All of them going out of the picture after 3 or 4 years. And they have gone out of the picture because they have an unacceptable failure rate. So why should we be the first one to adopt it and then give a lot of complications to the patient and then move on? So if you're the surgeon who is always adopting the technology that is as soon as it is published or as soon as it is promoted, or you adopt a technology which is the first one that comes in a lunch workshop, then you may not be the safest surgeon for your patients. No harm if you can just wait, lay back, look at what's happening around you for a few years, and then you'll have to get it. So I think technology is good. It's a double-edged knife.
Yeah.
It has lots of good and lots of things which you have to be careful about.
So in continuation to this discussion, do you think that there are any trends in spine surgery currently that might just get out of fashion or will be, standing the test of time? I mean, will it hold on or will it go?
I think many of these trends, the hottest thing in spine surgery is probably minimally invasive surgery. Incisions are getting smaller and smaller, and surgeons feel better and better as their incisions become smaller and smaller, and that is true. So even in that, we really need to be sure of what is the exact benefit to the. I am sure that there is a lot of benefit in the MIS in some aspects of spine surgery, but not in other aspects of spine surgery. So we really need to be careful about adopting it in all fields of spine surgery. Now, some surgeries, the minimally invasive surgery may be minimal invasive on the skin, but maybe maximally more restrictive inside. For example, if you take a microdiscectomy and compare it to endoscopy in a very tight canal stenosis, I mean, microdiscectomy has a 1-inch skin incision, but you can actually do a wonderful decompression inside without touching the facets, without doing a laminectomy. You can do that. But if you do an endoscopy, it is 1/4 the size of the skin incision, but you have to definitely take a little bit of the lamina. You have to do a medial facetectomy before you can safely identify the node. So there is a differentiation between minimally invasive outside and more invasive inside, or more invasive outside and minimally invasive inside. So I think over a period of time, all these things will get defined, and people will know what is the exact indications for this. I think more and more people will like also preventive aspects rather than the actually invasive surgeries. I think that's another thing that which will come in a big way into spine surgery.
So, as a spine surgeon, I mean, it's been a very hard and long day because you have to perform the roles of a clinician, a surgeon, as well as a researcher. So what has work-life balance been for you? Has it been a challenge? And what advice would you give to the young generation on this aspect?
Work-life balance, the current hot subject for young surgeons, not only in spine surgery, but I think in every field of surgery. Rohan, I am beyond 60 years now. And when I was your age, I'm not sure of your age, but still you look very young. So when I was, you both look very young. When I was your age, there was this concept, or I have never heard about this phrase work-life balance. We were always told, or we always thought that you have to work very hard, you have to train very hard. The more well you trained, you became a better surgeon, and the only way to become a better surgeon was to work very well, and that you cannot have a compartmentalization in your training, which means that my mentors used to say, if you have to train very well in trauma, if you saw a patient with an ankle fracture, then if you could see him in casualty, and also if you're on call, you operated on him and followed him and looked at him in your fracture clinic, you knew everything about the patient. But if you have to have a compartmentalized work, you work only 8 hours a day, and you see him in casualty, but someone else operates, someone else follows in the clinic, your training is going to be so compartmentalized that you can never be a very mature surgeon. So I really am not very sure that why this work-life balance concept came. And I also think there is a big problem in this phrase. The word balance makes you feel that you are balancing between two opposite things, isn't it? Balance.
Yes.
So it makes you feel that work is good, work is bad, and life is good. They are two opposite things. So this concept comes from this word work-life balance. And that is actually a big problem. The usual problem is, I think, work is very important, and also hard work is very important, because I have not seen anybody achieve anything big or great or something substantial without working hard. And if somebody has found a way of achieving success without working hard, I would like to know it, because that gives an easier method of enjoying your life. But the young surgeon must know the difference between hard work and stress. I think there is a lot of confusion between hard work and stress, and that's actually giving rise to this work-life balance. shoes. I strongly feel that hard work has not killed anybody, whereas stress has killed lots and lots of people. And we need to know the difference. Hard work is not working for 15 hours on something which you like very much, but stress is something that even working for 15 minutes on something which you don't enjoy. So if at the end of the day you are not happy, if at the end of the week you are not happy about what you are doing, I mean, rather than complaining about the work, you really need to sit down and consider and contemplate really, is this really what you want to do and is it what you are enjoying? So if there is a problem in that, you must change your ideas and what you need to do. Because you continue in the same pathway, you're going to get stressed more and more.
Yeah.
The second thing I have always understood by looking at many surgeons working around me is that stress comes from poor performance. This is very important. This is another mistake or misconception amongst young people. Now, let us take, I always tell all my residents, let's take two examples. We have one day, 6 complicated surgeries, all very difficult, and everything goes according to plan. You do very well. Everything goes, although you have worked and operated for 15 hours, that is the day which at the end of the day you are very, very happy. You have worked hard and you are very happy because good performance is one of the most important requirements for happiness. In contrast, there can be a day where you had only one discectomy to do. No hard work, simple surgery, 1 hour surgery or less. But there is a dural tear. You try to repair that and the tear becomes little bigger. There is a leak, the nerve roots are protruding, you get into problems, that, this, and that is the day you feel really stressed out. So, stress is related to something which you don't like doing, or stress comes from poor performance. And these two things, if you don't want to be stressed and you want to be happy with your work, you have to plan your work well. You have to train yourself very well. And you need to make sure that you win. I have looked around many people who feel stressed and who come and completely tell me I'm stressed. And one more thing I have noticed is that they all have got professional fatigue. And that comes from not learning or doing anything new over a period of time. If you are doing the same thing when you are 35, what you are doing at 30, and continue to do the same thing when you are 40 and 45, there is so much of boredom. There is nothing new in your work. So you get a lot of professional fatigue. And there is no incentive for you to, there is nothing exciting in the work. So you get really bad. So these are things that you need to look at. You need to keep reinventing yourself. I'm not saying you should do new, unwanted things, but you need to improve yourselves. And even on a professional scale, you can evolve over a period of time. Till 55, you can be doing a lot of surgeries, but after 55, you can do a lot of research, then you can do a lot of administration, professional leadership. So you must evolve over a period of time so that you never feel stressed. So that's my take on work. The other part of life is, I mean, how happy you are at home, it depends upon how good a personality you are and what is your personal vibrations with your partner, isn't it?
Yeah.
I mean, happy people are always happy. I mean, it really doesn't depend upon how much time you spend with your partner. It's the quality of time you spend with them, not the quantity of time. And if you both are able to share your aspirations, your ambitions, and you will really give a lot of support to each other, then you have happiness. And even if you spend very little time, that's a very good time. Whereas if you're not able to see eye to eye, spending a lot of time at home is also pretty dangerous. So basically, is happy couples are happy, I love these classifications in my mind. So couples, I always classify them as happy couples. They will be happy come what may. I mean, during periods of stress, during periods of training, periods of child, when they get children, they enjoy their children. They don't think children are stress. But there are another group, unhappy couples. They are unhappy because there is training for the husband. Then they are unhappy because the wife is training long hours. Then they are unhappy when the children come. They are unhappy when something happens. Basically, I think happy people and unhappy people in this world. So,
Okay.
I mean, you need to carefully look at how much you work, how you consider your work, what you think work is, what is life. This varies so much between person to person. We cannot generalize this
Yeah,
with
definitely.
everyone.
Yes, absolutely. So to
But
end,
people who are
sorry.
not productive, people who are not working well and who are not productive, or generally are the most unhappy persons in the
Yeah,
world.
that's a great message. Thank you.
Yeah.
So to end our really fascinating conversation, let's engage a quick game in which we ask you a question and you reply with a quick and fast answer. Okay. So what is your hobby, if you have one?
Hobby. So it's changed a little bit over a period of years. When I was in college, I used to read a lot of books and listening to music. But now I am a grandfather. So
Okay.
my favorite hobby used to be with lovely grandchildren because I mean, it's really sweet.
Yeah.
I mean, you may not understand it, but in time you will understand that grandchildren are much more beautiful than the most well written books.
And talking about books, what is your favorite book?
Yeah, my non-fiction books are my most favorite, although I read a lot of fiction books. So, Atlas Shrugged by Ayn Rand was one of my favorite books because it just showed me what it means to hold responsibilities and who are carrying the progress of the world. So, it's a very good philosophical book. And another big favorite is The Prophet by Khalil Gibran. So, I mean, these books are, I have read these books many times over
Yeah.
the last 30 years. And every time you read, you understand it a bit more. With your experience of life, you understand it a bit more.
And what is your favorite food?
Favorite food? My favorite food was a typical English breakfast. Was something which
Oh,
I really enjoyed when I was in UK,
okay.
and you know all the nice kebabs and tikka masalas at home is a
Wow.
good chicken biryani is something what I used to like very much.
Okay. And your favorite surgery?
Favorite surgery also has evolved over a period of time. I mean, when I learned microscope when my younger days, microdiscectomy, the beauty of seeing everything so nicely, removing intradural tumors was my favorite surgery. But now some of the things, surgery which gives me a lot of satisfaction is correction of major spinal deformities. So it's challenging, but also uh, the amount of it's impactful on the psychological benefit, the functional benefit, and the long-term results. So that's very fascinating.
And a word that defines spine surgery?
The word to define spine surgery, I think it's a demanding master. So, or if you say if you love spine surgery, it's a demanding lover. So
Okay.
it depends upon what you consider spine surgery.
Okay,
So
thank you.
it demands your attention, it demands your patience, it demands your time, and it demands a lot of hard work.
Thank you.
So
Yes.
Thank you very much.
So thank you so much for joining us today. I mean, it's
thank you,
been
Rohan.
like thoroughly inspirational for us and the
Yeah,
other young surgeons, especially of being a part of this AO Spine Youth Club. And it's been a true honor and privilege to have this with you.
Thank you, Rohan. Thank you, Gilberto. So it's been a great time, and it's been a
Yes.
privilege to discuss with both
Our.
of you. Thank you very much.
Thank you, sir.
Okay. Have a
Thank
nice
you.
day. Bye.
Have a nice evening, sir. Bye.
Thank you.